front of you is because of his encouragement and his support, and I've learned so much from him. So he's a really wonderful role model for me. And Dr. T.S. sir and Dr. Chapu sir, my teachers when I did my masters in health professions education, so I'm deeply indebted to them. So the topic given to me today is curriculum integration, bridging basic sciences with clinical training. Right? And I think the graphic there says it all. You have the keystone there, which is patient-centered application. And without that keystone, both these two drop. Okay, so on this side, the one in blue is related to patient care, and the one on the left is related to basic sciences. Right? And they become separate and they don't help each other. So what is the keystone is the patient-centered application of knowledge, which is what is going to be the overarching theme of this presentation. So, hitherto, the medical curriculum was like this, right? You could think of each part of the elephant as one subject, and the students were immersed in that subject without realizing that there is an elephant in the room, right? So, it was individual parts of the elephant that they were looking at, and at the end of that, they were expected to treat patients, right? But recognizing this, we have sort of introduced integration as an essential part of the new competency-based curriculum. So, if you look at the interest in integration, this is from an article in 2014, an A&E guide on integration. The research output on integration, when you use the search term curriculum integration, went up from near zero in 1983 to nearly 80 in 2013, and I'm sure this number has increased drastically since then. Right? So there is a recognition that integration is a very important area that needs to be researched upon. So what we're going to look at is we're going to look at curriculum integration. We're going to look at the rationale behind curriculum integration, a few definitions because there are multiple definitions that are floating around, and the main part of this talk is going to focus on the models of integration. Finally, we'll take a look at the educational strategies with which integration can be accomplished. And lastly, we look at the Indian context and what we've done so far in India in relation to the CBME with relation to integration. So these are the aspects that we're going to look at. So let's start off with the rationale. Of course, it seems obvious that integration needs to be there. However, we will begin at the end, right? So the end product of MBBS training, I'm sure all of you know this in your sleep. We've been driving it again and again and again for the BCME and for the CISP, is the so-called Indian medical graduate, right? Who's a compassionate and skilled basic doctor, right? So Indian medical graduate, the skilled and motivated basic doctor. So this is the end product that we expect at the end of the MBBS course. Right? However, our training is something like this. You have discrete bits of information being given to the student at different time points in the 4.5 years, and you expect them to put this information together to treat patients at the end of MBBS. Do you think that's a realistic thing for it to happen? It just doesn't happen like that. So, what is the difference between information and knowledge? So, in knowledge, we are able to use those discrete bits of information in the context of patient care, right? And integration is an attempt to do this in a very systematic and explicit manner, right? It's not something that happens by chance. It's done very explicitly, making these connections. So if you look at integrated learning, this infographic captures it in its essence. It has to happen in the student's mind. So it's very important to remember that integration has to happen in the student's mind. And our attempt is to ensure that those connections, we make it easier for those connections to happen, right? And that's the whole purpose of an integrated curriculum. And the rationale behind integration is that it is easier to retrieve and use information when it is combined in meaningful ways, right? When you combine information in meaningful ways, it is better remembered and more easily used. So a little bit about the neurobiology. So you have the hippocampus, which we know that it's used for recent memory traces, and in order for it to actually be embedded in the memory system, and for it to be able to be used, it has to go to the medial prefrontal cortex, right? And then you start making associations between those discrete bits of information. And basically, if you want to summarize this, neurons that fire together wire together, right? So you want neurons that fire together, they wire together. So you want that to happen in the student's brain. So I think we can just do this. If you can please use your mobile phones. And how many clinicians are here in the room? Can you please raise your hand, clinicians? And of course, many of you have, all of you have done some clinical work or the other. So please answer this. I'll just enlarge it. Yeah. Okay, so either only one person has answered or everyone has seen some impact of a lack of integration on patient care. How many of you have been able to answer it? How many of you? Okay, so many of you. So there's not a single no, right? So there's not a single no. So that means we have all seen or experienced situations in which a lack of application of integrated knowledge has directly impacted the patient. So I'll just move on. Okay, one no. Integration was the organization of teaching matter to interrelate or unify subjects frequently taught in separate academic courses or departments. Right? So this was the definition, classic definition proposed by Hardin way back in 1984. And it is self-explanatory, right? So we are trying to organize teaching matter to interrelate or unify subjects that are taught separately. And a more complex definition of an integrated curriculum was put forth in this AME guide, and this is the focus of this session. Is an integrated curriculum is a fully synchronous, transdisciplinary delivery of information between the foundational sciences and the applied sciences throughout all years of a medical school curriculum, right? So this is much more than the original definition proposed by Hardin, right? So here it implies that it is explicit and systematically done as part of the curriculum. The key words are highlighted: fully synchronous, transdisciplinary, bridge between foundational sciences and clinical sciences, and throughout all years of medical school. So keeping this definition in mind, let's look at some of the models that have been proposed for integration. Again, these have become very well known amongst medical education circles in India because we do it as part of the curriculum implementation and support program. So we are all familiar with this term called horizontal integration, where you try and interrelate the content that is done in a particular phase. In this case, for example, we could say anatomy, physiology and biochemistry, right? So we try and interrelate these three subjects in the same phase. Is called horizontal integration. Or we could have vertical integration, where we have subjects from different phases which we try and link together. That's called vertical integration. And how do we do these? There are many ways to do it. The more common ways are you have topics, common topics, like for example hemoglobin for physiology and biochemistry, or it could be organ systems. You could have a system based, right, like the respiratory system, cardiovascular system, or it could be case based, in which you have case scenarios which help us to integrate either horizontally or vertically. The other vertical integration, this was again from a paper in 2009. The traditional curriculum was H-shaped, even in India, right? So you have years of basic and classroom teaching, and then you have clinical practice, which are somewhat completely separate. The assumption is that this will be used for clinical practice, but there is no deliberate attempt to try and interrelate them. If you look at the Z-shaped curriculum, H to Z, you can see that at all stages you have some amount of basic science, and at all stages you have some amount of clinical science, right? Of course, the proportion varies. If you look at the, let's say year 1, there is a small amount of clinical practice embedded into the basic sciences,
Whereas when you go to the final year, there's a lot of matter related to clinical practice where you bring in a little bit of basic science as well, right? So from the H-shaped to the Z curriculum, H to Z. And then this also is a classic paper by Hardin called the spiral curriculum, where he says that there is, at the bottom you have all these three threads that go through the curriculum, right? Health promotion, ethics and clinical methods. And our AdCom module actually follows a spiral curriculum. Do you realize that? That is, the topic is built up in complexity from first year to the final year. If you take the communications module, for example, you have relatively more simple concepts covered in the first year, and that builds up towards the more complex concepts that go to the final year. So you have all these three running through, and in the first year you focus on normal structure, function and behavior, abnormal structure, function and behavior, clinical practice, and on-the-job learning. And you have on the top that big cone which looks at all three domains. That's the cognitive domain, affective domain and the psychomotor domain, right? So this concept has come in quite a bit, the spiral curriculum, and the AdCom module is, for example, a typical example of how we try and incorporate the spiral curriculum into our teaching. Another example is the linker session, all of you are aware of, right? Let's say that you have one linker session in anemia. In the first year you will cover certain aspects. Second year you will make it a little more complex. Third year you will make it even more complex, and fourth year. So you sort of build the case through the years. So that's an example of a spiral curriculum. This I think is the most widely used model for integration, again by Hardin in 2000. And these are the 11 steps in the ladder. At the bottom is isolation, and at the top is the nirvana of integration, which is transdisciplinary, where all departmental boundaries blur, right? So let's look at each of these steps very briefly. First, of course, is isolation. This was the case in most medical colleges before the CBME implementation, where we really did not bother about what another department was doing. It was done completely in isolation. The timetables, we didn't even talk to other departments. It was just done completely in isolation based on our own convenience, right? So the teaching is organized in silos, and there's no consideration of other subjects or disciplines. The second step is awareness, where you can see that there is that red dotted line, that square. So at least you become aware of what is being done in another subject. So maybe that could avoid a little bit of redundancy. The third is harmonization, where you can see that red box is becoming a little stronger, and maybe you have something called a phase coordinator, and there's an attempt to actually try and align the curriculum to a certain extent. The fourth is nesting. We are all familiar with this, and we've all been doing it for a long time. So basically incorporating some element of another subject in your teaching. Like for example, if I am teaching about inguinal canal, I may bring in a concept of inguinal hernia. So I am nesting surgery within anatomy, and vice versa. When a surgeon is maybe talking about inguinal hernia, they may nest a little bit of anatomy of the inguinal canal into their class. So that's an example of nesting, which all of us do, but it's something that's a terminology is being given to it. This is temporal coordination. Any idea what's it called in the CBME curriculum? Where we try and align topics. I've given you the hint, which are similar, right? We try and do it along the same timelines. Any idea what the name? Alignment, right? So what we call it, temporal coordination, is nothing but alignment. For example, when anatomy is doing thorax dissection, physiology may be doing cardiovascular physiology, biochemistry may be doing enzymes, cardiac enzymes. So all around the same time, we try and do it around the same time. So that is temporal coordination. Then sharing is nothing but co-teaching, right? So co-teaching, like for example, if there's a topic which has certain competencies in, let's say, physiology and biochemistry, let's say hemoglobin, then you remove the redundancies and both physio and biochem come together to teach the topic. Okay, so that is called sharing, co-teaching. And this is correlation, and you can see still the departments are there. You can see those 4 squares, but now the integration element is becoming a little larger. Okay, so this, you know what it's called in the CBME curriculum? This green box is called the linker session, right? Where you use a case scenario and you try and link all the subjects. And then as we move higher and higher, the departmental boundaries start blurring. We won't go into the details. So the departments become less and less important, and the integrated content becomes more and more important, right? So I won't go into the details, but you can just see the size of that red box with the red line is becoming larger and larger, and the departments are becoming smaller and smaller. Whereas in the previous models, departments were still large. And 9, 10 and 11 are multidisciplinary, interdisciplinary and transdisciplinary, where the departmental boundaries in transdisciplinary completely blur. So it is the complete body of knowledge that is available to humanity. Seems rather philosophical, right? But there are examples. If you go to his paper, you can see examples of even a transdisciplinary curriculum. So this is Hardin's model. So if you look at it, isolation, of course, everyone understands. Awareness, harmonization, nesting is more at an individual level, right? Then you go to temporal coordination, sharing and correlation. It's more at the course level, for a particular course. And when you go to complementary, multidisciplinary, inter and transdisciplinary, it's more at the level of the program, right? So the integration becomes a bigger and bigger component of the curriculum as you go higher and higher up in the ladder. Okay, so we've looked at the models. Now let's look at the educational strategies as to how to achieve this integration. So maybe you can just do this, please, if you can just scan this. And what methods do, okay, we've started getting responses. We'll take a look at the teaching learning methods and then take a look at the assessment methods. So lectures, okay. Vertical and horizontal, okay. Lectures, okay. Interdisciplinary. Case-based, yeah, case-based learning is coming out as a method. Case studies. Problems, okay. Fine. So these are some of the methods that have come out. Let's look at the assessment methods. Small group, linker, that's good, more and more are coming. Seminar, excellent. Okay. Now let's look at the assessments. You said MCQs, OSCE, structured essay, reflection papers, OSPE, OSCE. Okay, that's great. So let's take a look at some of the teaching learning methods that have been described in the literature and that we have used in St. John's as well. All of them have these two components, right? Any method that is used for integrated teaching and learning will have these two components. At some point or other, there will be complex real-life problem which the students have to engage with. And the second thing is there will be a collaborative approach. So both these are two key components when you look at teaching learning methods for integration, right? A collaborative approach and a complex real-life problem that they have to engage with. But the nitty-gritty of the methodology varies, right? And it's beyond the scope of this session to look at the nitty-gritty of the teaching learning methods, but almost all these methods will have these two components. So let's take a look at these methods. Flipped classroom. Some of you said lectures. So if you flip the lecture and make it a flipped classroom, you could encourage integration. So what is a flipped classroom? Any idea? Homework becomes classwork, classwork becomes homework. Traditionally, we take a class which is fact-filled and we give students homework to solve problems, but we just flip it. So here we give information to students beforehand and use the classroom session to solve problems. In this case, it could be a case scenario. Second is case-based learning. So basically we have a well-designed case and we ask higher level questions. And the questions are very important when you do case-based learning. It's the why and the how questions, right, that we need to ask that will help students to connect the preclinical or the phase basic sciences with the clinical sciences. Third is team-based learning. Again, a very feasible method for a linker session. It's a very detailed methodology. I won't go into this, but those of you who are interested can look this up. Team-based learning. It has a very specific connotation, right? There's a very specific process, but it will have complex real-life problems and it will involve a collaborative approach. Problem-based learning. I think ma'am took a workshop on problem-based learning. It is probably one of the best methods to encourage integration, right? Again, the only thing is it's a little time consuming and you require the facilitators for the groups, right? So you may have some logistic issues, but in terms of integration, it is one of the best methods if used well. And project-based learning. You can give your students projects to do in which they have to link things together. So these are some methods that can be used for integration. However, nesting can be used with any teaching learning method. Would you agree with me? Nesting can be used with any teaching learning method. You can nest some other subject into that teaching. Okay, so that's something that we must think about and deliberately nest clinical or basic sciences into our sessions, right? So this is about the teaching learning methods. Coming to the assessments, I think this is so true even now, maybe more so. This is Sir William Osler. It's really nice that one here and one here, both are William Osler, right? We make the examination the end of education, not an accessory in its acquisition. The student is given the impression that he is in the school to pass certain examinations, and I am afraid the society in which he moves grinds this impression into the soul, right? So the assessment is just a tool for him to become a good doctor, right? And we need to keep that in mind when we look at integrated assessments. So scenario-based questions, you said MCQs, essays, short essays. If we include scenario-based questions, automatically the student will be forced to integrate, right? To connect bits and pieces and provide the answer. So how many of you are using scenario-based questions? Can you please raise your hands? Yeah. So that is a very powerful tool of integrated assessment. Concept maps, right? Is another nice mapping, is another way in which you can assess students' ability to connect. And this is an example of a concept map about coffee, right? So it's basically a concept map about coffee. It talks about how coffee can be made, about caffeine, what the effects of coffee are. So in this one picture, it tells you a lot about coffee, right? So like this, imagine for disease conditions, the student can create concept maps. You can ask them to create concept maps. The third is mind maps. This is an example of a mind map. So you have, let's say, anemia, and you look at the different types of anemia. It's like from the center, you have branches going out, and you can create, it's more pictorial than the concept map. So it's very picture based and it's very graphic in its nature, graphical in its nature. So this is the mind map. And then, how many of you make it a point to ask why and how questions during the viva or during a long case or short case? Very important. So keep that in mind, please. When you are having an oral examination or any practical examination, at least ask one why question and one how question. Okay, that will force the students to connect the clinical and the basic sciences. And finally, of course, you can give them assignments in which, for example, this is right from the NMC module. So they could submit an assignment on a particular content of the curriculum in which they are forced to link the basic sciences and the clinical sciences. So these are some methods of assessment of integrated assessments. Finally, we'll end by looking at the Indian context. Pre-CDMA, this was the scenario, right? Let's say that this was a topic related to blood or anemia. ANAT would do something in the first week, biochemistry in the third week, physio in the second week, and that would continue through the course. So everything occurred in isolation, right? Departments didn't work together. But post CDME, what has happened is, this is the suggestion, right? That there will be 80-20, in the paraclinical 60-40, and the clinical 20-80 integration, just like that Z shape. And as a result of this, we are focusing on these four now, right? In the CDMA curriculum, we are focusing on these four steps of the ladder: nesting, temporal coordination, sharing, and correlation, right? Other word for correlation is linker. So after CDME, at least we are trying to align our timetables to make sure that similar topics across subjects are taught around the same time. So this is alignment. So we are trying to align the content. Second is post CDME, there is a deliberate attempt to do nesting. Nesting is a very powerful way of integration, both horizontal and vertical. So it's more explicitly stated, and we are trying to do nesting in a very deliberate manner. And finally, we are trying to link things together, right? We are having the sharing and correlation, we are having the linker sessions. So we are trying to use case scenarios to link concepts, right? So a lot has changed post CDME in terms of our understanding and our implementation of integration. However, there are certain challenges that are ahead of us if we really have to have an integrated curriculum. First and foremost is the curriculum overload and time constraints. This is a real problem, and unless we address this problem, there are no easy solutions. But one solution that is very, very important is for departments to talk to one another. It's very important for all departments to talk together when they are framing the timetable. And in fact, it would be good if you can call clinicians into, when you are framing the first year timetable, please include clinicians as well, right? I'm sure with a lot of departmental crosstalk, we can reduce this curriculum overload and sort of, to a certain extent, circumvent the time constraints. Second is faculty resistance. The first thing when you tell faculty, oh no, not one more thing. I'm already doing 100 things. This is the 101st thing on my plate. Okay, so overcoming faculty resistance is a big issue. And of course, the departments are still siloed. We are still very, very focused on our own departments, very blinkered in our views. So we need to have a more expansive view. And we need to incorporate integrated assessment methods. I think still we are lagging behind in this. Have you seen the new CDME assessment, in which you have the integrated topics and 4 questions have to come from that? So to a certain extent, we are trying to address this through the new question paper format. And finally, of course, institutional support and faculty development are essential, and we need a much greater coverage of the CISP program and ensure that all faculty undergo the CISP. So with that I end, and just to summarize, we looked at the rationale behind integration and neurons that fire together, wire together. That's basically the rationale. We looked at certain definitions, Hardin's definition of integration and what an integrated curriculum is. We looked at certain models, horizontal, vertical, the 11 steps in Hardin's ladder, and which is the other model that we looked at? Do you remember? Spiral, the spiral curriculum by Hardin. Then we looked at certain educational strategies. Most of the educational strategies have complex real-life scenarios and collaborative efforts in order to integrate. And the assessment tools also have to be ensure that the student is required to link things together. And mapping is a very underutilized tool for assessment. It can be used. And last but not the least, we looked at the Indian context, and a lot of improvements have occurred with the new competency-based curriculum, but there are a lot of challenges that lie ahead of us, which I'm sure if all of us work together, we can overcome. So thank you very much for your patient hearing, and if there are questions, I'd be happy to answer.